Hello, everyone. I'm Charlie Reavis, President of Dysphonia International. I want to welcome you to our webinar today titled Ask the Experts Q&A session. Reminder that the webinar is being recorded and we will be available on our YouTube channel and our website at dysphonia.org. We encourage your questions, and clearly, since this webinar is all Q&A, put your thinking cap on and get your questions in mind. And as Kim said, please submit your questions by typing them in the Q&A box on your Zoom screen. It's just much easier for us to operate out of the Q&A box. And we would ask that you keep your questions more of a generic nature because it's not really an appropriate forum for Dr. Rubin or Dr. Codino to try to give anyone an analysis or a diagnosis here during the webinar. So I wanted to remind you that we will answer all the questions as time permits. However, if we do not get all the questions answered during this session, they will be answered and included as part of the webinar on our website. So I am extremely pleased to introduce our guest speakers, Dr. Adam Rubin and Dr. Juliana Codino. Dr. Rubin is a laryngologist and director of the Lakeshore Professional Voice Center at Lakeshore Ear, Nose, and Throat in St. Clair Shores, Michigan. Dr. Rubin is also affiliated with multiple hospitals in the greater Detroit area. Prior to obtaining his medical degree from Harvard Medical School, Dr. Rubin was a professional actor and singer. And during his acting and singing career, he developed an understanding of the need for expert care for professional voices, and I would add everyday voice. In 2014, he wrote a book titled The Vocal Pit Stop, Keeping Your Voice on Track. And I happen to have read the book and reviewed a couple of times, and I came across an interesting comment that Dr. Rubin really had directed to professional voice users, but I think it applies to everyone. The comment is, be informed. Your voice is your profession as well as your personality. Abuse it, you may lose it. Dr. Rubin is active in vocal research, has written numerous medical articles and book chapters on voice. Dr. Juliana Codino is director of voice pathology and is supervisor of the SLP Voice-Centric Clinical Fellowship at Lakeshore Professional Voice Center in St. Clair Shores, Michigan. Juliana maintains a strong interest in research with a focus on acoustics of voice production. She has been teaching acoustical analysis of voice and phonetics for many years. She has written several research articles, book chapters, and has also been a reviewer of many scientific presentations in various journals. Juliana has a background in medical theater and enjoys singing. I had the pleasure of meeting Dr. Rubin and Dr. Codino during a fall voice conference several years ago. And it has been a pleasure knowing and working with them over the years. They are not only a terrific voice care team, but they are also a fun and talented performing team. And they are just incredible supporters of our organization, of the local support group in Michigan, our Walk for Talk events they're very active in, and they support the entire dysphonia community. So we're just extremely pleased to have both of them as our guest speakers this evening today for our webinar. So, Dr. Rubin, you want to open with a couple of comments?
Well, thank you, Charlie, for those really kind introductions. We are excited to be here. As Charlie said, Dr. Codino and I are the voice team. Well, actually, we have two other significant members in-house who are clinical fellows in voice pathology that we train. And we work together as a team to take care of all patients with voice disorders, as well as swallowing and airway as well. We love taking care of our patients with laryngeal dystonia. It's a very gratifying privilege to be able to do that. But we really enjoy caring for any patient who comes in with a problem with his or her voice, because as we all know, our voice is, probably our most effective, if not our most successful means of communication. And I don't have to convince anyone on this webinar right now how difficult it is when you struggle with your voice, particularly for a long period of time. So we're excited to be here, be challenged by your questions potentially, and have a good discussion. And we are happy to take questions on any issue, not just dystonia, but any issue you might wonder about. Dr. Codino, you have anything to add to that, or?
I think you laid the ground. And well, I want to add that we are also excited to collaborate and support the Walk for Talk, which is coming in Detroit Saturday, not next Saturday, the following, the 14th, at the Troy Nature Center. And not only we love supporting the cause, but we also love playing and singing, and we're going to play with our band there. So for any locals, we hope to see you there, October 14th, 11 a.m. at the Troy Nature Center.
In fact, we're retiring tonight and we're going to go on the road. It's going to be, no, I'm just kidding. So I think it's called the Stage Nature Center. It's in Troy, and it's from 11 to 1:45, I think.
Yeah.
Hopefully the weather is beautiful. Beautiful Michigan fall weather.
Yes.
Fantastic. Let me just toss out something, Dr. Rubin. What comes up quite frequently that I hear, and I'll start with kind of focusing in on the treatment for spasmodic dystonia to start with, but could you talk a little bit about the different techniques, procedures of actually doing the Botox injections? Absolutely.
So there are, a few different techniques people use to inject Botox. Some people use an electromyography and a special needle to inject through the skin of the neck. And they don't actually visualize the needle with a scope or anything, but they use the EMG to try to identify the muscle by having people do certain tasks, whether it's say E or a sniff if it's abductor dystonia. The advantage of that for the patient is they don't have a scope in their nose. So if they can stay out of the airway, they may not need a lidocaine injection. But the disadvantage is it's still, even though it's very effective in the right hands, there are a lot of muscles that contract when you say E. So in my opinion, you can never be 100% certain that you're in the correct muscle. And I think there's a high incidence of perhaps missing. Little easier for the PCA, for the abductor muscle, because it's only one muscle activates significantly when you sniff. And then there are other techniques, what we call transcervical techniques, which typically do require a scope in the nose as well for visualization. You can go from below. It's called the cricothyroid technique because it goes through the cricothyroid membrane. I prefer to go from above because you see your needle very well. That's called the thyrohyoid approach, and you go through the thyrohyoid membrane. You come from above the vocal folds. You enter the larynx, actually through the epiglottis, and you're able to see your needle and direct it exactly where you want it to go. There is another technique out there called, it's been referred to as point and touch, which actually also is done without the scope. I don't think many people do it this way, but they basically go through the thyroid cartilage, and then once they feel they're through the thyroid cartilage, just when they get through, they should be in the muscle. and they inject that way. I think that pretty much sums up all the different injection techniques. When any technique which requires, you know, a needle going into the airway does require an injection of 4% topical lidocaine, which isn't so fun, as many of you I'm sure know, and it makes you cough pretty vigorously there for a few seconds, but people seem to get used to it.
Thank you, Dr. Rubin. Now, could you talk a little bit about how speech therapy is a complement to Botox injections for people, and maybe also what is the time frame that you recommend for people to get speech therapy after they get an injection? So if you could talk a bit about that.
Yeah, I'll take this one. As you said, Charlie, the role of voice therapy is to complement. It's never the primary treatment for laryngeal dystonias. We know that it's not the gold standard. We use it because as a complement, typically after the injection, to maximize the effects of the injection. Regarding the timeline, we typically recommend our patients to wait that initial breathiness period to start with the voice exercises, because trying to achieve the efficient voicing that we're looking for with the exercises while they're struggling with the initial breathiness might not be ideal. And in other cases, we use voice therapy as a diagnostic tool because we're not so certain if what we're dealing with is with a primary muscle tension dysphonia or with a laryngeal dystonia. They may overlap, and I don't think I've ever met a patient with laryngeal dystonia that didn't have a component of muscle tension. It's basically the compensatory adjustments that the body does to try to, if their vocal folds are spasming, to try to prevent the spasms or gain some stability from those disruptive muscle spasms or firing that are happening. So in that case, we would do the voice therapy prior to recommending the injection. Sometimes, as I said, if it's the case of a primary muscle tension dysphonia, we discover that the patient didn't need Botox, and the gold standard treatment for that disorder is voice therapy. Other times, after a course of voice therapy, well, we're deciding sometimes which muscle we want to inject if we're going to do Botox. Voice therapy may unload and kind of like unmask the symptoms. So then we have the true disorder, neurological disorder showing, and that will guide us in deciding where we want to inject for that specific patient.
You know, I think it's really a very important adjunct. I don't know that everyone does that, but certainly with, you know, after the initial treatment, having that therapy afterwards certainly will help maximize the effect and reduce any residual, additional muscle tension, and diagnostically incredibly important too. In fact, sometimes, the dystonia is really classic and clear cut. Many times it's a little trickier, and you don't want to commit someone to Botox if it's just a primary muscle tension dysphonia, although they might respond to the Botox actually. So I kind of feel they're the gold standard of, can the voice therapist cure this? If they can, it's not spasmodic dysphonia or laryngeal dystonia. And then if they can't, does Botox do the trick? And at that point, you have confirmed your diagnosis. I do want to go back. There was one other technique for injection I left. There are probably still people who do what's called transoral, where they take a curved needle through the mouth, again requiring a scope in the nose, but a curved needle through the mouth and then go into the vocal fold that way.
Good. Excellent. Thank both of you. Question: what are the parts of the body involved in producing speech? How would a weakness in any of those parts affect the nervous system?
Out of my way, Adam.
Go for it. You're good.
So we usually like to explain, actually, our patients this, because we're trying to explain why we're doing certain exercises. The vocal mechanism can be divided into 3 subsystems. the breath support, which is the power source for the voice, then the oscillator, which is the vocal folds itself housed inside the larynx, and then the resonators, where we acquire the specific color, timbre of our voices. And all those three systems need to work together in balance to achieve the most efficient voice with the least amount of effort and the best quality possible. So any disorder in any of these three subsystems will affect the output, the end result of that voice. So if we have spasms in the muscles of the larynx, the oscillator will be out of whack. So the breath support has to try to compensate. Sometimes with the resonators, we can try to bypass the disorder here by maximizing the use of the resonators. Sometimes the disorder is big enough that we cannot bypass it by maximizing the other two subsystems. And in the case of laryngeal dystonias, sometimes, or tremors of the voice, it's not only the laryngeal muscles that are involved. Sometimes we have tremors of the soft palate. We have tremors in head tremors, and that will obviously affect also the voice. I think you said, what was the second part of your question, Charlie?
I just lost my,
I think you said that. No, you said
Q&A here.
It's okay, because you said any weakness in which part of the...
Right.
I answered that too.
Yep. Here's an interesting one. Have you dealt with people with SD adductor with vocal tremors and slight vocal paralysis? Does it get worse? Does Botox in the vocal folds help? What else might help?
So you said they have adductor SD.
Correct.
Tremor.
Correct.
And slight and paresis.
Correct.
Interesting. Well, let's just take part of that. There's a spectrum of movement disorder of the vocal folds, right? You have one end pure dystonia, one end pure tremor, and then you have everything in between, which is some combination of pure dystonia and tremor, and some may be more tremor dominant, some might be more dystonia dominant, and that can make it a little tricky at times. The more tremor, although the Botox certainly helps, it's not quite as effective as it is for pure dystonia. Now, if you're going to start to throw paresis in there, a lot would depend on how significant the paresis is, how severe, how the paresis in and of itself is affecting the voice, whether you're, in a sense, if you're really not, if it's impairing your closure of your vocal folds, it's probably going to make the spasms less noticeable. So I think it's a kind of a difficult question to answer without, seeing specifically what the vocal folds are doing.
And remember, before Botox, laryngeal dystonias were treated with nerve resection. So we do have some patients that had in the 80s a nerve resection. So they come with adductor spasmodic dysphonia and a vocal fold paralysis on the other side. And
it sort of shows that was not the best treatment for it, right? It seems to always recur after cutting the nerve, and that's probably because it's more, we realize now it's a more complex disorder than just a motor disorder of the muscles contracting too much. There's sensory feedback loops that are involved and numerous neural networks that are involved. So it's the disorder is much more complicated than we thought in the past, or that people before me thought in the past.
Good point. Interesting question. The person is asking, can you discuss the role of cervical dystonia in dysphonia? I think the person may be asking about if we know that some people have both cervical dystonia and spasmodic dysphonia. So I'm not exactly sure what this person may be asking.
Well, maybe they're asking for just cervical dystonia, how that can affect the voice, and it certainly could. It certainly could, because any additional, your whole body's involved in voice production, and any spasms of the cervical muscles are probably going to lead to, additional tension that's going to probably affect your voice production. So I think that it certainly could. Dr. Codino, do you have anything to add to that?
I'm just thinking about, we have a patient with cervical dystonia, and they get Botox for their cervical dystonia. They usually time it in the same week, ideally like 1 or 2 days apart from the laryngeal Botox that they get with us. And yeah, they have to treat both.
But they have both. They have SD as well. So hopefully we answered your question.
Good. Person is asking, my voice spasms seem very erratic, and I don't know why I sometimes can speak without the spasms. And I also feel like it is situational, which makes me think it is something that I caused to happen. I've been diagnosed with AD, SD, but also mentioned that I have a vocal tremor.
Well, inconsistency in the presentation of the spasms usually kind of like makes us wonder, is this diagnosis adequate? Because one of the things that we can trust with laryngeal dystonias is that it's pretty consistent. I don't know the details on this specific case, but when we have a patient that presents with spasms and they say, oh, sometimes there are 2 or 3 days that I don't have them, or even a couple of hours throughout my day, my voice is completely normal, we question the accuracy of the diagnosis, and we treat it, maybe as we said before, let's see how much of these symptoms are compensatory adjustments that this person is doing, either because it's a secondary muscle tension dysphonia to another disorder, or a primary muscle tension dysphonia. And that's where where we use voice therapy as a diagnostic tool.
So I agree with all that, but I'll play devil's advocate in the sense that we still don't completely understand this disorder. So I don't put anything beyond the realms of possibility. And also, we do know that there are, it depends how variable it is, but there are times where your voice is going to be better than others. We know a little bit of wine might help the tremor. We know talking on the phone tends to be worse, things like that. But yeah, if there's tremendous inconsistency and people go days without any symptoms, that does make us wonder.
And one thing that I didn't say, it's never the patient causing the symptom.
Right.
It's never the patient causing the symptom. So to whoever wrote that, you didn't cause this, you're not causing it. The body, we do funky things, funky adjustments the whole time. Imagine having to run a marathon with a pebble inside your shoe. You're gonna run weird, right? Trying to compensate for it. So I think the main issue is finding the right diagnosis to treat it appropriately. And as Dr. Rubin said, it may be overlapping also, or it may be, a variety of things. So we know stress can increase some of the symptoms for laryngeal dystonias. So
I just want to jump in for a couple of things, because I want to make sure everyone knows what these are. When we talk about primary muscle tension dysphonia, what that means is a dysphonia presumably caused by excessive muscle tension for no other reason. Okay. And that can either be just, maybe I'll be a little hoarse at the end of this talk because I'm not thinking about my posture and how I'm speaking, or sometimes it can be what we refer to as a functional voice disorder, which could be like a conversion disorder. Conversion disorder is when your body does funny things because of stress, underlying stress, stress or anxiety that you might be dealing with fine because you have to do your job and take care of your kids, but then the body manifests that stress in a different, odd way. A secondary muscle tension dysphonia is hoarseness caused by excessive muscle tension that is related to having another underlying issue, whether it's small nodules or dystonia, or what'd you say, Dr. Codino?
I said, a paralysis, anything
Right.
that is impairing the right function of the oscillator, we develop a secondary muscle tension dysphonia.
And one other distinction I want to make, just so people understand, because you'll hear these different terms. Well, someone asked about speech. Speech refers to articulation. So if someone came in talking like that would be what we call dysarthria. That's a speech disorder. Whereas voice is related to the quality of your voice, the tone. So spasmodic dysphonia or laryngeal dystonia is a voice disorder.
Great, good distinction to make sure people understand that difference between speech and voice. Good question here. Is there any evidence that Botox shots for dysphonia affect the thyroid and/or immune system?
None that I know of.
Are they asking because of the proximity with the injection? Maybe we can.
I suspect so, Juliana.
Do you want to?
None that I'm aware of. I wouldn't know. I couldn't really fathom in my head the mechanism that would show that cause and effect.
Here's another question again that seems that tremor is just so prevalent in so many people. The question is there a connection between tremors in the hand and spasmodic dysphonia?
So, a fair number of people with one movement disorder have other parts of the body affected. I can't remember the percentages. So I expect if you have tremor in the hand and a dystonia, you probably have some of that is actual tremor, voice tremor. I suspect that it's not pure dystonia. That's what I would guess.
Sometimes people with voice tremors, they present in the clinic with no treatment, obviously, and we are like, oh, this sounds like an abductory spasmodic dysphonia, for instance, which is the variant that has spasms in the abduction, the opening of the vocal folds. And then after a course of voice therapy, when we're trying to figure out what's going on, that's what I was trying to say before, we realized that those abductory spasms was part of the secondary muscle tension, trying to stabilize the voice and keep it nice and steady. And then after a course of voice therapy, the true tremor shows itself. So that would be one of the examples that we actually dealt with not too long ago.
Interesting. This comes up quite frequently too. If a neurologist and a laryngologist disagree on what voice disorder a person has, spasmodic dysphonia or essential tremor, which diagnosis should one trust?
Well, that's a great point. I'm biased, obviously. So, I would tell you that the laryngologist, because we're voice specialists. The neurologists are not voice specialists, but they're good compatriots and part of the team on dealing with patients with voice disorders, particularly if there are other aspects, if they have head tremor, palatal tremor, extremity tremor. Medication for those other types of tremors don't typically help voice tremors. So, typically, Botox is needed for that. But the long and the short of it, if you're seeing a voice team, laryngologist, hopefully laryngologist and voice pathologist, I would trust them more. But I can't give you an absolute.
Sometimes as patients, it's good to advocate for yourselves and ask your physicians, your team. Yeah. So how many patients with this disorder that you just diagnosed me with, how many do you treat? Ask a little bit and see how involved in the disorder and the treatment of that specific disorder they are.
And please don't tell any of my referring neurologists that I said that, okay? Now, I will tell you one other thing. Let's take that example. Is it tremor? Is it adductor dystonia? The answer might end up coming out when you do the Botox, because if it's pure adductor dystonia, you're going to have, very clean results, right? I mean, usually we're able to get rid of the spasms, often completely if it's pure. Whereas if it's tremor or more component, it's unlikely going to be a complete normalization of the voice, if that makes sense.
Yeah.
So ultimately the difference doesn't matter that much, in terms of who's right or who's wrong, because if you want treatment for those disorders, you're going to end up getting botulinum toxin injection, and that might reveal the answer.
Sorry, I have my dog here. One thing that we usually tell patients with tremor if they're getting their first Botox injection to treat it is that we hear from our patients with tremor that even though the tremor does not completely go away with Botox, the effort it takes to talk is significantly reduced. So that is still a win, even though there's still some degree of tremor in their voice.
Okay, excellent. Good question here is this person saying, I have mixed dysphonia. Do you have experience and results using the Gore-Tex patch, since Botox has not been of value to me?
So I think she's talking about what we call laryngoplasty or thyroplasty, which is putting an implant in, drilling a window in the thyroid cartilage in the voice box, and tucking an implant in there. Often with vocal folds that move, we use Gore-Tex. I have done a thyroplasty on one of my abductor patients, which has helped. They still need Botox. Mixed dystonias are tough, because a number of both your adductors and your abductors are involved, and sometimes I have one patient with a mix that she does fine when I just inject the thyroretinoid muscles. I have others where I have to inject both the thyroretinoids and the PCAs, and this is an art. It's not, it's not a pure, it's not a easy question, not a pure scientific answer. And sometimes you have to just play with different doses, with different muscles you're injecting, and it may take a little while to find the ideal solution. That said, if the voice is particularly breathy, you could consider it. It's not a guarantee, but what you could do is before you jump to a Gore-Tex implant, you could have the laryngologist do what we call a trial injection laryngoplasty. And what they would do is instead they would inject a filler into your vocal folds to plump them up, and that will give the same effect of helping the closure of the vocal folds. So I certainly would say if you're considering a Gore-Tex implant, you got to try the injection laryngoplasty first, because if that doesn't work, it's not worth the risk of having a more significant surgery, having an implant, within your larynx. In general, we don't have same complications with them, but you can.
Yeah. Patients with the abductory variant, in some places they do offer the repeated injection laryngoplasty with a filler as treatment, because Botox to that muscle, the posterior cricoid muscle, will cause breathing problems. So you can't do sometimes the high injection that you would like to do to reduce the spasms, because then that patient is going to develop severe breathing problems. And I've heard, and I know that some places they offer that line of treatment too for abductory variant.
Excellent. Good comments and input for everybody. This question is interesting, and I used to receive Botox injections once every 6 months. Now it is 4 months, and my voice is raspy and does not seem to return to normal. Does your body become immune to the Botox and it is no longer effective?
You can get Botox resistance. You can, and typically what people do, they'll switch to Botox B. I haven't had to do that in my career yet. So if it's
those first, right?
Yes, exactly. I mean, if you're just getting shorter duration, maybe you increase the dose, but you can get resistance. And actually, that's why we tell all our Botox patients, do not get cosmetic Botox, because then you're starting to put 100 units in the face at a time. You're putting much higher doses. So stay as beautiful as you are. You don't need anything else, and just save it for the vocal folds.
And sometimes we can also not only adjust the dose, and we had, I can think of at least one case where this patient had been doing Botox injections into the TA muscle for adductory variant with good success. We had him for years. And at some point, it didn't work as well. We tweaked the dosage. He was coming more often. And then we switched to false vocal fold injections.
Yes, that's a great point. Yep.
And that was what evidently at that time worked. And he's been getting false vocal fold injections since then, with good results. So there's many things to try before we think about Botox. Botox is not working for me anymore.
Right, and we have a lot of, laryngeal dystonia patients, and we have not had to switch. So yeah, that's not to say it won't happen, but
yeah,
I think too, Dr. Rubin, the dosage that we get for our voice condition is so small.
yes.
It's not very conducive to building antibodies to that amount, I believe.
No, that's why we don't want to avoid the cosmetic Botox, which is much higher doses.
Yeah. Here's a really interesting question. It said, can you provide any tips or insight to those of us who are aspiring voice clinicians?
Right.
Oh. Yes.
Go ahead, Dr. Codino.
So studying never ends. That's the main one. There's get in touch with people who do what you love, what you aspire to do. Go to conferences, try to connect, these kind of things. Even though I know that probably this webinar was more designed for questions from patients, it's great that you're here, for instance. That's a great way to be in the know. Because then when you decide to go into the world, apply for a fellowship or apply for residency, I don't know which area they're wanting to go into, but all these things, these connections and this knowledge is gonna pay back. So good job for being here.
Absolutely. Thank you for being interested in voice. Not only on as a person living with a voice condition, but on behalf of our entire voice community. Thank you very much.
Good choice.
Excellent choice.
We'll choose it again if we had to. I think I speak for both of us.
Oh yes.
Interesting one. Can you discuss more about breath support? I am very breathy and have a marked head tremor. Cold and stress make even speaking very difficult at times, with the need to stop speaking and take a breath between each word.
You want to jump on that? That's good enough.
Yeah. As I said before, breath is kind of like the power source for voice production. And it's not uncommon that patients with voice disorders, any voice disorder, they say, oh, I have shortness of breath when I'm talking. It's not necessarily that you're having shortness of breath. You're probably winded because you're not using the air as effectively as you could. There may be some leaking of air because you have, for instance, a polyp or a paralysis and the vocal folds are not closing as efficiently as they should. And in the case of laryngeal dystonias, all these disruptive spasms or even the tremor will probably affect it. So it's not uncommon. Part of voice therapy, as I said, post Botox injection will give you some exercises. And I think, Charlie, in your website, Sarah Schneider has fantastic resources there. Not that voice therapy is a recipe that it's one fits all, not at all, but at least something to get started if you don't have immediate access to a voice specialist or a voice team near you. Maybe you can try there. Breathing exercises can certainly help raise awareness of how to use the air when you're speaking. So maybe that's a way to start, and eventually reach out to your physician, to your group of physicians, and see if you would benefit from a course of voice therapy to work with your breath.
I mean, if you have a severe vocal tremor, you probably are leaking a lot of air. And if it's severe enough, it's, you are going to feel winded. You also feel whenever there's a problem closing the vocal folds, whether it's speaking or not, you have difficulty doing it. We all micro Valsalva all the time and bear down, and if you lose the ability to do that too, that causes shortness of breath. That's why people with unilateral one paralyzed vocal fold, they'll they'll often feel winded just with exercise. They'll be winded when they talk, but they'll also be winded when they exercise because they can't get that Valsalva, those micro Valsalvas that helps us climb trees and things like that. So I don't want to speak as a voice pathologist, but one thing you can do is to shorten your phrases, shorten your segments, take more breaths, more frequently. So you're not trying to, use one breath on an extended period of time. Did I say that correctly, Dr. Codino?
Did. Great. You can speak almost as a voice pathologist.
When you work closely with someone, you learn from each other. So when we train our voice pathologists, I want them thinking also like a laryngologist as well as a voice pathologist. And I've been able to think like a voice pathologist, getting to work with Dr. Codino.
Fantastic. So building on that team concept, let's talk a little bit about treatment options for people with idiopathic vocal fold paralysis, paresis.
So I'll jump on this, Dr. Codino. So, obviously the first thing you have a paralyzed vocal fold, you have to have a CAT scan in your neck and chest. And so to rule out any tumor compressing on the nerve, that's number one. So I'm assuming you have, if you've been diagnosed with idiopathic, but if you haven't, that needs to be done. So a lot depends on where the position of the paralyzed vocal fold is and whether or not you can get your vocal folds to close, or if you can't get them to close, how big is the gap when you try to get them to close? Okay, so we always look at these cases together and we just, decide together whether we think it's worth a trial of voice therapy, because there are certain therapy exercises that will assist in not only glottic closure, but providing the breath support. Obviously, if you can't close your vocal folds as well, you need more breath, because the vocal folds close, they produce a seal to build up pressure below it so the breath can cause them to vibrate. So one option, if the glottic gap is not very large, if the gap between the vocal folds is not very large, is to try some voice therapy. Beyond that, we are great at providing geometric solutions to this problem. We're not great at making a nerve work again. And if we could, I always tell my patients, if I could do that, I'll be speaking at the Nobel Prize ceremony. So, so in the first, that's a little controversial. Some people say 6 months, some people say a year to give it time to recover. I tend to go somewhere between that, around 9 months. If it's not back, I don't really expect the nerve to regain function. In the time being, to avoid suffering, we offer an injection laryngoplasty, to a filler that I talked about before, to bulk up the paralyzed vocal fold and help you close your vocal folds better. And that's a very effective treatment. Doesn't make your nerve work again. It doesn't make your nerve not work. And then if the nerve hasn't recovered by 9 months to a year, depending on what you believe, then you can have a permanent procedure, a thyroplasty, which is an implant. We alluded to this before, and that can be a Gore-Tex implant. For bigger gaps, we use a silastic implant. There are also other procedures, something called a arytenoid adduction and a arytnopexy, which involves surgically rotating the arytenoid cartilage, which is the cartilage that the vocal fold's attached to, that opens and closes the vocal fold. So those are the main treatment options for it. But hopefully, a lot of cases, the nerve will regain function.
Okay, great. Thank you. This person is saying, I have essential voice tremor and started getting Botox injections in my false vocal cords through my nasal passage. When I got it before through my throat, I would lose my voice for 5 weeks. Now I only am hard to understand for about 2 weeks. I have read about that procedure in the NSDA publication or Dysphonia International publication. I wish more people that lose their voice for so long knew about this. Could you comment, Dr. Rubin?
Well, I'm a little confused. Both techniques were using we're using false vocal fold injections. If you could just text that real fast. There are people who might inject through a ported laryngoscope through the nose. I guess I should have mentioned that too as a possibility. I don't think a lot of people do that, but through the nose through like a sclerotherapy needle, or there's a newer device that came out recently out of Boston. But it's just a technique. It shouldn't affect, if they're injecting the same structure with the same dose, it shouldn't really affect how long you're breathy for, whether or not they go through the mouth, the throat, the neck or not.
Could it be EMG versus?
Now, if you're talking about someone's going in blind through EMG, then I would say the difference there is just a more accurate injection, because it's done under a direct visualization. Did they answer, Charlie? Hang on, you're muted. You're muted still. Sorry. You're still muted. Can't hear you. There you go.
Okay. Yes, I think that covered what the person was asking.
Okay.
This is one of them. Can you tell us your go-to vocal hygiene tips for professional voice users?
Wow, it's a long answer. Go ahead, you can start.
Let's see if we can cover it in less than an hour.
You can read the vocal pit stop, keeping your voice on track. That's number one. Right. Go ahead, yeah.
Well, the main thing that we have to deal with when we're treating a professional voice user is the vocal load. And we like to discuss vocal budgeting. And I always tell my patients with different analogies, but I like imagine you get a certain limited amount of voice tokens a day and you have to use them wisely. If you have a performance that night, don't meet for lunch with a group of noisy friends at a bar where you're going to be overusing your voice and maybe feeling a little bit fatigued right after. So planning and deciding which are the things that you want to invest those voice tokens in is crucial with professional voice users. We also talk a lot about, well, indirect voice therapy when including this, but we talk about hydration, avoiding irritants to the throat, cough or throat clearing suppression, avoiding those kind of behaviors like yelling, screaming, phonotraumatic behaviors in general. If they do have to yell on stage because their performance requires that, there's techniques for healthy yelling, so we work on that. Obviously smoking and being exposed to things that may inflame the tissues in the voice box in general. We discuss that too. Healthy habits, your voice is not isolated from your body, so you have to keep your body healthy. Obviously hydration and all those things that I was talking about smoking have to do with that. And then vocal technique. If this is a professional singer, and they like to, for instance, change voice teachers every couple of months, that's not a great idea. Obviously, you need to find a teacher that you like, but just doing it to test the waters in different places might mess up the technique, and the student singer might end up confused instead of very well trained with many techniques. So what am I
seeing appropriate repertoire. I want to say though, remember, professional voice is not just singers and actors. It's doctors, lawyers, teachers. We have a lot of patients who are teachers and they have to teach for 8 hours a day and they had no vocal training, and they're coming in, they're 29 years old and they're wondering if they're gonna be able to do this for another 20 years because they're struggling. But I always say there are 3 secrets to a prolonged to a long career, professional career, and that's prevention of vocal injury with all this vocal hygiene, early recognition of vocal injury. So, people tend to write off hoarseness as, oh, I have laryngitis, or I have allergies, or I have, reflux. Those things don't cause hoarseness for 2 weeks, 3 weeks. Those persistent hoarseness, that has to be evaluated. So prevention, recognition, and then appropriate treatment, making sure you're in the right hands and getting appropriate treatment for whatever the diagnosis is.
And I'm going to do another shameless plug. In a couple of, I can't remember exactly, I'm the worst doing shameless plugs, but at the end of October, I'm going to be talking to grad students in speech language pathology in the group called Foundations of a Voice Clinician. And we'll talk about taking care of the performer. So if this person is interested in voice, they can join. This is a free webinar also. So look it up on Instagram or somewhere. And I hate not knowing the date, but it's somewhere at the end of October.
Great, good comments, guys. We have two or three or four perhaps questions related to a laryngeal vibration device. There's been a study going on for a while at University of Minnesota by Dr. Konkek, and the people are asking if you guys have experience with that device. And I saw a couple of questions here. I think we're kind of relating to exactly what is that device doing?
So first of all, we don't use it. We're not part of the study. I actually was at our national conference. We were talking about this. I don't think the data is really defined as of yet, or definitive, I should say. There are other things too. Mike Pittman had a internal device that it was implantable onto the vocal fold. The whole thought with these things is to alter the gamma loop, the sensory feedback loop that affects tonicity, the tone of the muscle. I think the verdict is still out.
We always like to mention to our patients all the new, clinical trials, studies that are happening out there, because I think it's great that if you get involved and you are part of it. I think that it can't hurt. Obviously, there's risks, but at least being in touch with these groups as a patient with a disorder, with all the great things that are happening currently in Boston. Dr. Simonian is doing great things. The STEP lab, Dr. Marks, is doing amazing things with acoustics for laryngeal dystonia. So being in touch as a patient with these places that open their doors to patients, I think it's very interesting. As you said, Minnesota.
I think my hunch is there's not going to be one size fits all, and some things are going to work for some people and not for others. So, there are things that are not invasive, and then there are other things out there, as we know, deep brain stimulation, things like that, which are being investigated, which are a bit more invasive. I would just always err on caution until there's some more, really definitive research that has proven efficacy, particularly as it gets more invasive. And, honestly, I think botulinum toxin injections, although uncomfortable, they're still standard of care, and will probably remain that way for a while. And if you can tolerate them and they're having good effects, I don't know that I would jump to deep brain stimulation, for example.
I know I've noticed a few questions where people would like to talk to you guys specifically and directly. So let me just encourage all of you, all the participants. You can get contact information for Dr. Rubin and Dr. Codino from our website, dysphonia.org, and go to the healthcare referral listing. And so their contact information is listed there, and you can contact them. Here's one I was looking for, Dr. Rubin, and you and Juliana have kind of touched on this before, but I've seen 2 or 3 questions about this topic. It says, my Botox is no longer working despite numerous attempts to change the shot location as well as the medication, I presume, dosage. What are the other promising treatments that are available now and may be in the near future?
I don't know that I can answer that fully. I mean, I think I'd want to know if they were tried on another form of Botox in case they're developing resistance. I think that's what I would go first if they've really exhausted all other possibilities in terms of false vocal fold injections, altering dosage, and things like that. Otherwise, the things that are out there, I think Simonian is also still doing studies on oxybutyn, which sort of it's kind of like taking a pill, alcohol in a pill form. I can't speak to the efficacy. I think it does work, but you feel, a little woozy probably. And then the other, topics are these, the deep brain stimulator and this vibrator. I think the implantable device that I just gave some talks with Dr. Pittman, so I know that is sort of has gone by the wayside. It was effective in some cases, I guess not effective enough for any company to invest the money into to mass produce it. So I wish I could give you a better answer than that, but unfortunately I can't.
Thank you, sir. Here's really a question that affects a lot of people, and Dr. Rubin, as you commented before, because a lot of teachers develop voice problems for whatever reason. And this person is saying they were diagnosed with muscle tension dysphonia, and they have started speech therapy. And this person is about 40 years old. And the question is, do you see a lot of people around that age who are teachers who get muscle tension dysphonia?
We see tons of teachers with voice issues. And I would just caution and just make sure that you've had a video stroboscopy, which is, a test that's going to evaluate not just the structure of your vocal folds and their vibratory capability to make sure that the diagnosis is correct. But there often is a component of muscle tension dysphonia in teachers who present with voice disorders. So I think, I expect that no one saw a big polyp on your vocal fold or anything like that. Maybe they're missing a little bit of scar, but it's hard to say. But I think trying voice therapy is a very reasonable approach. We encourage our teachers to always use amplification in the classroom. So hopefully you can get a doctor's note you can bring to your principal. That's usually kind of effective to get amplification. Otherwise, there are, relatively inexpensive amplifiers on Amazon. One with a little headset, which is pretty good, a little portable speaker you carry on your body, and it's $35. So you can look at that. Dr. Codino, do you want to add to that at all?
Yeah, no, I think she mentioned the age being a variable. Honestly, any profession at any age with increased voice use, you're at risk to develop some sort of voice disorder. So it doesn't have necessarily to do with age. Obviously, the longer you drag a voice problem without treating it, probably the worse it may get. But any, as Dr. Rubin said, any teacher that has the vocal demands that these teachers have in a day. I learned during COVID when I had to homeschool my kids for a couple of weeks, and I'm like, oh, this is really tough, not only from the vocal perspective, but dealing with other things that were happening at the time, obviously. So they're voice professionals, and they have to treat their instrument with a lot of care if they want to do that for the rest of their lives. So they have to assume themselves as vocal athletes and take care of that instrument as the highest priority.
Dr. Codino reminded me yesterday, I meant to say when we were talking about professional voice users, but this applies to teachers as well, is a lot of times, especially the high-end singers have been doing this for a while, they kind of take it for granted. Not as much anymore because there's more, out there now, discussing this. But so when I was a professional actor, I remember my first job, which was right after college, all of a sudden I'm rehearsing day in, day out, but then I'm going out and having a drink or two and, chowing down a burger and, talking to people over loud noise, not, just thinking that, not recognizing that was probably going to be, cause problems. And, all of a sudden the next rehearsal, wow, I'm not quite where I was before. And then there was a steady decline. And then all of a sudden, like, oh my gosh, am I going to be able to get on stage and do this? And even Broadway performers, have to perform 8 shows a week, right? 4 shows, 2 shows on Saturday, 2 shows on Sunday. I don't care how well trained you are. That is inhuman, so they're very common problems. A lot of Broadway performers end up taking steroids frequently to reduce inflammation, just to keep themselves on stage. So Dr. Codino and I are vocally tired after talking to patients for 8 hours. So, and that's just one-on-one. You're talking to classrooms of 25, 30 people sometimes. And so it's a very challenging profession. Definitely get amplification and, get good training.
And the amplification is never a sign of weakness. It's a
No.
sign of being smart, of knowing what your day awaits. So never, let anyone tell you, oh, you don't need it. You're fine as you are. You're strong enough. No. It's being smart.
Excellent. I think we'll end with this question and the person is asking, are there any other means to lessen the effects of SD adductor with vocal tremors when giving long speeches? I'm not getting Botox and only dealing with speech therapy at this point. I give lots of public speeches to hundreds of people.
So I'm sorry, I was reading something in the chat and I got distracted.
Yeah, let me repeat, Juliana. They're asking, are there any other means to lessen the effects of SD adductor with vocal tremors when giving long speeches? And currently this person is getting some speech therapy, but they are not getting Botox.
Okay. Yeah, as Dr. Rubin mentioned before, one of the things that we when a patient decides not to get Botox, and specifically with voice tremors, Dr. Julie Barkmeyer-Kramer in Utah developed a protocol for treating voice tremors behaviorally. That means with exercises. And one of the things that she discusses, and I found it very efficient with patients with voice tremor, is to kind of like use what we call telegraphic speech. Is a means to hide the tremor. It will not fix it, but using shorter utterances, and that needs training. It's not just, okay, speak in shorter phrases, because that's what the protocol proposes. That might be one way to deal with it. And then, as I said before, I don't think I've ever met a patient with laryngeal dystonia that didn't have a component of muscle tension. So working with those resonators, trying to maximize the effects of the resonators to try to bypass the problems that are happening at the level of the vocal folds is also something that we recommend. Public speakers, obviously, again, amplification, rehearsing the speech before, choosing where they're gonna chop or decide to use, for instance, some of the resonant voice strategies more than in other places of the speech. That's always a good idea. And then, of course, everything we said before about breath support, being mindful of not speaking until you run out of air and you're using the reserve air. All those things apply to any conversation, but I think I would tackle those things.
And however you can do it, lose any self-consciousness or anything like that, because anything nerves, getting nervous, getting stage fright, anything like that is going to exacerbate it. So, be proud of what you're doing and don't worry about what other people think. Yeah. Easier said than done. I know that. I just wanted to throw in there before we completely end and everyone that if you want to sit back, enjoy some good fun, Dr. Codino and I host a World Voice Day concert every year. A lot of our patients sing, we sing, and it's a public awareness event. And if you go to YouTube and you search Lakeshore Voice Center, you can find a lot of our concerts there, which, if you're bored, it's a lot of fun.
Absolutely is. And thank you, both of you, so much. It's been, as always, amazing how quickly the time goes by. And can't thank both of you enough for all you do for us and the entire community. It's been great discussion, great information. And again, I would encourage people, go to our website, dysphonia.org, look on the healthcare referral listing, And you will find contact information for Dr. Rubin and Dr. Codino if you want to contact them directly. I'm sure they would welcome you to do that. And the other quick comment I want to make before too many of you jump off, I know we had more questions that we didn't get to. Unfortunately, some of you had your questions in the chat box, and I was not able to flip back and forth between the chat and the Q&A to pick up all of those. So again, we will get those questions answered for you, and they will be part of the webinar, and it will be on our website probably in a couple of weeks or so. So again, Dr. Rubin, Dr. Codino, thank both of you so much. Appreciate it.
Thank you. We consider this a privilege to get to care for, to get to do what we do, and to share our knowledge, and hopefully we've helped some people out there understand things a little better.
Absolutely.
Yeah.
And thank all of you for participating, and we look forward to seeing you on our next webinar. All the best. So long.
Bye.
Bye, everyone.